We all have seen the barriers we face. It's going to be done off of here. Yeah. We've all seen the barriers we face in education today for our trainees. So there's too little time. There are now too few cases, or there's too much information that they have to learn. It's too expensive to take the time out from our clinical practice to train them or to develop simulation centers. And we're also, our residents are spread wide and far geographically, so you can't really develop efficient training paradigms because they're all separate. E-learning is something that can overcome a lot of these problems, all right? It uses an efficient use of time. It allows you to develop structured presentations for the trainees, and it is very cost effective once you get over the development costs. And this, we're not novel in figuring this out. These are two books. One is called The Innovator's Dilemma, if anybody's read that book, by Clayton Christensen, which talks about disruptive technology. Well, he thinks that one of the prime areas, the two most prime areas for disruptive technology is in education and in medicine. And in his second book, Disrupting Class, he talks just how e-learning is going to radically change the way we do K through 12 education, the way we do postgraduate education, and similarly, I think it's a way that we can change education for cardiothoracic surgery. Well, what does it look like? So the first thing you have to sort of distinguish is between e-content, which you see a lot of out there, and e-learning. E-content is simply a display of content electronically. And it should not be confused with e-learning, where there is actual instructional design put into the way that the content is presented to the trainee. You can add assessment forms. It really comes in sort of three sort of blended ways. The first would be standalone or self-paced. These include some things like just-in-time learning. You see this when you need to learn how to put on a new brake pad on a 57 Chevy. You can go and find a quick 5-minute video that tells you exactly what screws to remove, where to put the pad, how to tighten it, how to check it, and you're done. And in about 10 minutes, you can get a teaching video on that. On the other end, you can have self-paced course like Phoenix. The University of Phoenix has massive self-paced study courses which cover multiple months of study and are well orchestrated. You can go to virtual classrooms, and I'll go into a little more time on each of these, and you can even do blended learning. But when we look at cardiothoracic education, what you see here is the bare bones structure of developing a curriculum. This is all the steps necessary to build an educational curriculum, and really the area where it sort of focuses in on these two areas. Once you decide what you want your graduate to look like, what are the needs of that graduate, the next step is to set the goals and objectives. What are the various elements you're going to have to teach the resident or the trainee in order to ensure that they can practice the way you want? And then once you know what those goals and objectives are, the next step is going to be to determine the instructional methods to teach those various objectives. And we're focused a lot on technical, but we know in general thoracic surgery, case in point, a lot of our education is in decision making. A lot of the decision making that we train the residents to make is what determines a good outcome or a bad outcome. And so there are different types of objectives that we want to teach our residents. And different objectives, the way they're structured, will require different instructional methods. And educators and PhD educators spend a lot of time trying to develop taxonomies to describe various objectives, because if you can categorize the objective, you can easily identify which instructional method works best for each objective type. And it's similar to staging a patient, all right? You can stage the objectives. That would be your analogy. Simple objectives on the low end of this scale by Bloom is things like remembering and understanding, knowing what the anatomy is, understanding how to calculate pulmonary function testing and postoperative predictive pulmonary function testing, understanding what are the findings of a pulmonary malignancy on a CT scan or on a plain chest x-ray. Those are basic objectives, and they're called low-level cognitive dimensions, or not very higher order thinking skills. The trainee is just asked to spit out something from memory. At the other end of the spectrum are much more complex things like creating and evaluating, creating a treatment plan, creating a plan for attack in the OR, creating a plan for evaluating a patient who's not doing well postoperatively. These aren't things that are memorized. These are higher order skills, higher order cognition, and they're much harder to teach. You have to get at them with a different method than what is required for just remembering and understanding. Now, Bloom's taxonomy was built mostly for K through 12 education. It's a bit cumbersome for most people to understand, and so there are simplified taxonomies. And the most simplified one is this. There's sort of 3 stages. It's triangular. At the base is knowledge, From that, what you do is you retrieve and understand informations and concepts. It's the most simplest type of teaching we do to the residents when we pimp them. This is what we're really asking them to do, is recall knowledge. From that, you can build on skills. That's where you apply knowledge when performing a basic task. So if I give them the data on a patient and I say, calculate the predicted postoperative FEV1, they're going to have to take their knowledge that they learned at the knowledge level and apply it to this skill. The next, the most complex, is an ability. And that's where they take multiple skills and multiple pieces of information and you link them all together to do a very complex task. So if I ask them to stage a patient with lung cancer, that's an ability. It's going to require understanding how the CAT scan and the benefits and the advantages and disadvantages of staging with CAT scan, of EBUS, as we heard this morning, of importing information from PET scanning and putting all that information together to come and stage a patient is a very complex ability. And it's really not something we can teach them simply by having them read. It requires more practice than it does just self-study. Well, as you can get from the levels of objectives, different instructional methods require different resource utilization. And if you graft it out with the dimension of cognitive process going up over here on the x and on the y-axis, or on the x-axis you have resource utilization, what you'll see is when you have simple things like content, it requires very little resources, but it also doesn't really hit very high cognitive dimensions. I mean, really, that's only going to hit things like remembering and maybe understanding. As you start to add complexity to the instructional method, so you add instruction, meaning you don't just throw all the content at them, but you organize the content, you set it up specifically, you'll highlight which content is most important. Well, that takes time and uses more resources, but it also hits higher cognitive dimensions. And so on, when you start adding assessment tools, and then finally when you start adding interaction between the learner and the teachers and between the learners, that becomes enormous resource utilization, but it also allows you to hit those cognitive dimensions at the very upper end of what we want our trainees to know. How do you plan a treatment plan for a patient? How do you determine how to stage or evaluate a patient? Well, as I said, the e-learning options that are available, I'll go over a little more detail on each one. There is knowledge or content management. And so you'll see things like content management systems or CMSs. Really all these are, as the analogy is, it's an electronic version of a library, all right? It is all the content that we have or we deem important for our field placed online. And it can include anything, since it's e-learning, include videos, still images, PowerPoint talks, Adobe Presenter talks, as well as book chapters and more standard things like readings. Its advantages are it is really simple to develop. I mean, essentially all you got to do is get the stuff online. It is simple to update. As new information comes on, you take the old stuff off. And it is exceedingly low cost. I mean, with storage capacity now, you can get a lot of content management system support for next to nothing, for really chump change. In fact, most of them are free, and the one we're exploring that I'll talk to you in a minute is iTunes University. It's totally free, all right? We're loading everything up on there without any cost. The problem with it is there's no instruction. Just like you wouldn't send a medical student to the library at the beginning of their first year and say, come back after 2 years when you're ready to go into the wards. And there's no instruction in that, all right? There's just this massive amount of content, totally unorganized. They're not going to learn anything. They're just going to go in there, they'll read the books they like. They're not going to know what they need to know. They're totally going to miss the boat. And so content management is not education. Content management is simply a library, and it's where our resources are held. In addition, part and parcel of that, there's no assessment. So if you did send them into the library, there's no way to find out if they actually learned anything. So usually content management does not include. Now you can add content that has built-in assessments, but that's very different. Content management systems don't track that stuff. They don't keep track of it. They don't compare it. They don't see progress. That's not what they're built for. They're a library. Well, what about when you start getting into instructional systems like standalone or self-paced courses? So these standalone courses, this is how I did my master's essentially for a lot of what I did in my master's degree for education. A lot of these were standalone or self-paced. There would be reading assignments, there would be assignments to do as homework, and then that homework would be handed in, and you'd get a grade from that homework. The beauty of this is there's no time constraint, so it fits very well into our training paradigm as we have. You can develop short courses that stand on focused topics. For example, How do you calculate the postoperative FEV1 of a patient that's undergoing resection? All that could be packaged into a neat little course with assessments built in. It can be cheap, it's automated. The residents will all be at a level playing field in understanding these skills when they walk into your rotation. There's hundreds of other examples that you could do for this. I mean, staging system, all these sorts of things which are low level, but what you get as I'm talking to you is they're really difficult in these areas to teach abilities, those higher order cognitive skills. What they're really meant for is lower order, remembering, understanding, maybe some basic skill level sort of cognition. The other thing is the initial development costs can be high, not really in financial costs, but in time. Somebody's got to sit down and organize the content in such a way and present it in such a way. That takes time. And as I'll show you, part of the 3 rollouts that we're doing for e-learning in our training right now has involved quite a bit of time just to develop these courses. And then the other thing is the updates can be a little bit difficult. I mean, it's more than just changing the content. As new developments occur, the whole focus of the course and the objectives of the course may have to develop. Now, for basic things like calculating pulmonary function tests and those sorts of things, they're not going to change. But obviously, as the staging system changes and gets updated and new staging modalities come online like EBUS, you're going to have to radically change the course and the outline of the course and the content that's covered. A subgroup of standalone or self-paced courses are mobile or just-in-time learning. These are these short 5-minute teaching episodes, and they're very popular in industry. A lot of people have done these courses as well, and the example of the other ones is when you have your hospital-based sort of documentation or your employee, you know, to make sure that you don't violate your HR rules. You all have to do these sorts of standalone courses. But these mobile or just-in-time are exceedingly short. They're supposed to be focused on maybe 1 or 2 teaching elements. And they're beautiful in that they mostly cover very simple basic knowledges. They're quick to develop and update because you're hitting really basic topics. And you can even include limited assessment in these things. And examples of where you could do this is positioning a patient for a thoracotomy. I mean, you could develop a really short, simple, 5-minute online mobile app teaching course. The resident could walk on his way walking to the OR, could quickly review what are the steps in positioning a patient for a thoracotomy, positioning a patient for a sternotomy. All those sorts of things can be included in these, and they're very short. The problem with them is, again, you really can only teach very, very limited things like knowledge, maybe some basic skills, and the assessments that you included there are pretty limited. And although they're improving the collection of the data from the assessments, most of these are sort of standalone. The assessments are built into the course, and that's that. You don't really get to collate that data and present it sort of for a national demonstration that they're moving up the ladder. Again, most of these are used in industries, like I said at the beginning, like installing a brake pad or changing an oil filter. These are perfectly adapted for those sorts of things. Another one is learning games and simulation. Now this is probably something that can go to the next level. These do have no time constraints as well. The trainees can work on these things anything they want. They can actually address all forms of cognition. You can go to really higher order training with these things and really teach some very, very important and sort of high level cognitive skills like creating. And you can put in both formative and summative assessments. I mean, the classic example is Fundamentals of Surgery, put out by the American College of Surgeons. This is a virtual reality simulator that takes you through the process of evaluating and treating patients with about 13 or 15 different common sort of post-operative complications. And it is a heavily intense simulation, and as you would imagine, they have very high development costs. I mean, these things take a lot of planning. You have to do a bulletin board. They're simulations, so you have to predict all the possible responses from the trainees and have really a logical series of events for them. And just like they're difficult to create, they are even more difficult to update. As changes come online, this is something that costs, you know, a lot of money to develop. And this is what the airline and the military have. And this is something that where we're going to have to find novel ways of developing these sorts of things because the cost is really going to resist us being able to do this at individual institutions. The next big group is the virtual classroom, and this is really akin to how I did my entire, and this was really where I got my interest in this. I watched my then 15-year-old in high school preparing for a test for his midterm exams, and when I went in to watch what he was doing, he was on Facebook. And I was like, really? I mean, you're really on Facebook while you're in the middle of studying for your exams? And he swore to me that he was studying. And I went and I looked at the thread of the discussion, and he was not lying. He and his fellow students had commandeered Facebook as a way to interact socially and discuss. They had loaded teaching plans and worksheets. They were asking each other about the question that the teacher had asked. They were contacting former students in the class, and they were getting information about what this teacher liked to ask on their test. And they had commandeered a system that was not built for education, that was built for social media, and it turned it into a very viable teaching tool. And these are the learners that we're now training. They not only can do this, they expect to do this. And the virtual classroom is where they do it. It comes in really two forms: synchronous and asynchronous. So when you mean synchronous, you're thinking about webinars. You're thinking about chat rooms. This is where the teachers and the students are online at the same time. They're interacting just like they would in a classroom, except virtually completely. On the other hand, the asynchronous one, the students and the instructors are not online simultaneously. They can interact whenever their time is available to them, and they use threaded discussions like chat rooms, but with time space between them. So somebody would start a themed discussion and say, look, I'm interested in this, and then maybe 2 hours later somebody else in the class would add a comment about that, and then another comment, and then fragment discussions can grow off that. You can split the themes, and it is exceedingly effective. And this is not just from watching my son do it, but from personal experience. Most of my core courses in my master's course were done this way. And I was being instructed with people from Beirut and from people from Pakistan and from multiple learners in Canada. And we were all online and we were all doing our coursework simultaneously, and it was exceedingly effective. In fact, some people say that it's more effective than classroom learning, because for those individuals who are slightly introverted and don't feel comfortable making a comment to the teacher in front of the class, the online forum allows them to communicate with the teacher and with others in the classroom much more effectively than they would if they get drowned out by the fast talkers and the ones who dominate the discussion. Well, the advantages are of virtual classroom is, since you have this interaction, you can address all forms of cognition, especially ability, because the teacher can act as a coach just like they would when you're in the clinic with your resident. You have the availability of assessments. Every form of assessment, including written assignments, can be put in here. You can assess the communication that goes on between the students as getting a very in-depth look at what they're actually thinking and how they're trying to solve these problems as they go through it. It allows broad reach. It overcomes the geographical barriers. And I'll show you exactly what I mean when I go into phase 3 of what we're doing right now. And the key is it allows student to student and student to teacher interactions, which is exactly what happens in our residency now. When we teach these complex skills, we teach it in the operating room, one-on-one with our trainees, or we teach it to them in the clinic or on the wards, one-on-one. They do not come into the clinic already knowing how to do this stuff. They have to try it, fail, get feedback, retry it, fail, and keep tweaking it until they get it right. And you can do that on this. In addition, because there's input from the faculty, these things are easy to update. You just change an assignment, the teacher's involved. Just like you can update a curriculum, you can update these. The problem is there is a bit of a time constraint. Obviously, it's asynchronous, but it still has to happen at the same time of the year. And so these courses have to be scheduled. You're going to start maybe at the beginning of the month and end at the end of the month. There'll be multiple assignments. But that's something we can work on, and we can see what flies. In addition, there's some relative development costs, but the biggest cost is the continuing cost. There's going to have to be a faculty member who is actually going to be the teacher for this course. Now, when you look at it from the cost for that one individual, the development and the continuing costs are pretty high. But when you look at the fact that this one system can reach 25 or 30 residents simultaneously across the country, the overall cost nationally comes way down. The final one is blended learning, and that's where you link real classrooms with virtual learning. And the problem here is this just isn't suitable for us. It's being used in a lot of situations, but it's probably not adaptable for us, and it's really going to just bring in all the problems that a real classroom has in cardiothoracic surgery that we're just not going to be able to use. Well, what are we doing right now? Currently, we're trying to build this, and it's not me. There's a whole host of people, many of whom are in this audience. I know Jules is here. I know Steve Yang is here. I know Shanda has helped with us. There's a number of people involved in this. But the first phase is this, and it's going on right now. Ed Bender, who you've all heard of, who developed the apps that you see on the Apple, the iPhone, is also working with us. The Joint Council, the TSDA, is working us at length. But the idea first is to develop the online content source. So we're already in negotiations and contractual negotiations with Apple to develop a site on iTunes University. Unfortunately, I think you all heard that they had this big announcement about a month and a half ago about iTunes, and they really want to update their educational platform on iTunes University. As such, they put some restrictions saying it would only be through K through 12 and 2- and 4-year universities. But we've got a hold of some people there through Ed and through Jim Fan, actually, and we're hoping that there's a contract going through and we will have a site on iTunes University for all of our content. The beauty of iTunes University, as I said, is it's free. You can access it from any device that has a browser, so any smartphone, Android, iPhone, iPads, any tablet can get to it, any computer can get to it. As long as you have an internet browser, you can get to it. The idea is we're going to put all of our relevant content on here. PowerPoint talks that are currently in the TSDA curriculum, videos, images that are on CTSNet, all of this will get housed in one place. It allows you to store, it's simple, it's quick to do. Now, one of the biggest problems with this is we're going to have to develop some sort of an editorial review board, a board that will vet the content and say, look, this is the content that should be on the website. This content doesn't really hit any additional marks and we may want to leave it out. Now, that sort of thing is going to be an ongoing time-consuming thing, but I think we're already in works of developing a structure for that. It'll look sort of like an editorial board for a journal. We'll have divisions and groups that are responsible for their sections. They will review periodically every 3 to 5 years the content that's online and say, well, it should be updated in this area, etc. We're going to bring the trainees into it. The TSRA is exceedingly excited about this idea. As you know, they developed their own book electronically just a year ago that's out for free. This is the type of thing that they're looking for, some guidance in what the content is, what they need to learn. Now, we're going to put it in iTunes University, but then where we want to display it is on this thing called the personal brain, and this is through Craig Baker at USC, and the idea actually came to us from Europe, but I'll just show you sort of the way this thing works. You can see it right here. This would be our cardiothoracic surgery curriculum. And since Craig Baker is a cardiac surgeon, most of the data that's been uploaded here, although he's put everything on, but if you look, you go to cardiovascular surgery and it shows you all the topics that currently exist in cardiovascular surgery. And so a resident could peruse here and come down to say heart valve, and I'll show you all the topics on that, and then you could say, well, I'm interested in mitral valve disease. It'll show you that. Well, I'm interested in mitral regurg. It'll show you that. And then when you look under mitral repair, it's got every article that is currently loaded on the TSDA curriculum up here. And you can see if it's an image, you can come down here and you can look at it. You can pull the PDF file. Now, there are some issues that come up with this, big-time issues of copyright. And we're working through those issues to try and make sure that we don't all get dragged off to jail in the process of developing that. But this is currently underway, and we'll probably go live within the next 6 months as soon as we get the copyright issues sort of sorted out. So the next phase is to develop self-study course development. And that's also undergoing right now, and that's the thing that Tom Varghese, Steve Yang, Jules Lin have all been helping me with. And the idea here is to develop self-study courses based on low-level knowledge. Now, we're not trying to hit everything. Graciously, the American Board of Thoracic Surgery, and especially Mark Allen, helped us out by giving us data from the American Board of Thoracic Surgery, and particularly from the oral exam, in the areas that our trainees do poorly on. Where are they failing? Where are the gaps in our educational curriculum right now? And as you would expect, and especially the ones who have participated in the board process, there are some large gaps in certain expected areas. The most expected one was tracheal surgery for thoracic surgeons. There are enormous gaps, and our trainees consistently do poorly in tracheal surgery. On the other hand, in cardiac surgery, there are some large gaps in aortic surgery as well, as you would expect. And that's because you know the reasons. These are diseases that occur in centralized areas in the country. They're not ubiquitously seen across the country, and so the ability to be exposed to these diseases is limited. So our trainees are really stuck learning about these diseases from textbooks. But the oral exam doesn't ask them for that information. The oral exam asks them for higher level ability sort of knowledge, and that's something that's going to require some higher order instructional design. But to get them there, we first got to get them the knowledge base and the skill base. And so the second phase is to develop these self-study courses. And the self-study courses that we've selected are ones that feed into the decision-making of tracheal surgery. The content is going to be selected by a course developer. There is going to be assessments poured in, and then these are going to assess primarily knowledge and skills. And we've already developed this, and where we've gone to develop this is an open source system called Moodle. I'll tell you about Moodle. This is the Moodle site that we've already developed. We are currently taking it off of CTS.net because they're unwilling to support us anymore, and putting it on a vendor. Moodle is open source, meaning anyone can download this program off the internet for free, just like Wikipedia is open source. And it is now the largest used open source, or the largest used teaching platform in the world. It was started in 2003 at MIT. It now has over 1 million users and about 140,000 different institutions. And it did that, I'll show you graphically, it did that pretty darn quick. That's the rise since 2003. It is massive, and it is free, and they've done updates. They are now on Moodle 2.0, and Moodle 2.0 embeds every form of assessment you can imagine, from essay writing to multiple choice to long answer to short answer to multi-response. It allows thematic discussions, it allows chat rooms, it allows forums, it allows any content to display. It's building a plugin right now for iTunes University, so all the content iTunes will play on Moodle. It already has a Moodle app, or excuse me, it already has a Moodle app that allows it to go to YouTube, and it has one for Shutterfly, so images can be loaded on Shutterfly and immediately updated. You can even update a video, so if you wanted them to submit a video of them doing a mediastinoscopy so you could assess them, they could actually upload themselves doing a video mediastinoscope and upload it. So the course right now that we've developed on this are short, freestanding courses on, say, how to calculate pulmonary function, on surgical procedures for tracheal disease, on surgical diseases of trachea, and these sorts of things. And the trainees will do these courses at whatever their leisure, take the assessments, of which I have to thank Fred and again the American Board for sending us the CSATs. We've embedded all of the CSATs questions that are relevant to this. The 4 courses that we've developed now have almost 200 questions embedded in them. And the architecture of Moodle is such that they won't take the same course twice. They won't take the same test twice. They'll take the test, and then the test will go to the question bank and randomly give them another set of questions. So they can't just sit there and go through the quiz 5 times until they get 100%. And so it's got a lot of safety features. And then the third phase is building these real high order courses. And again, the intent is not to build this for everything. The intent is not to replace the unbelievable teaching that happens on the wards and in the clinic and in the operating room. The idea here is to build some ability to teach those subjects that are not ubiquitously accessible to all our trainees across the country and bring them up to a level playing field. Again, we're going to use Moodle. It's free. We can build this. As I said, it's going to be based on ABTS performance, and it's going to be specifically focused on abilities. So the course right now, as it's outlined, is 5 weeks long. The first week is sort of get them up to speed with how things work on Moodle. The second course is just on diagnosis. The third week is on evaluation, staging, and such not. And the fourth week is on treatment and complications. And so each week they will focus on a different area of decision making and then move forward to the next one sort of in an ordered fashion. So in the end, I think that our educational system is overrun with multiple barriers, and we're going to have to think outside the box. None of these barriers are going to go away. Our learners have changed. They are not the same learner they were 10, even 20 years ago, and our practices have changed. Our practices are not what they were 10 or 20 years ago. I think e-learning provides multiple advantages in organization, standardization, accessibility, and efficiency, and it does have one limitation, and that is major development costs up front. But I think down the line, there are tremendous opportunities to standardize our educational system and at least hit those areas where we currently are doing a very weak job. Thanks.